Well, it's Monday. It's freezing cold. We had you had a very traumatic weekend, as far as I understand it,
Yeah.
with the gale force winds, and so let's be kind to ourselves on Mondays, and not take ourselves too seriously, because stress is not good for us on any level, is it?
No, no. And that's what we're here to talk about as well.
Well, yeah, it is a fascinating connection, isn't it? Certainly between the breath and stress, and the breath and the pelvic floor. And this is our topic of conversation, the wonderful mechanics of the pelvic floor. What can go wrong, and what we can do to help ourselves when these things come upon us and happen to us, which is something that happens to lots of people. And so we're talking pelvic floor dysfunction, and this can be something that people experience unknowingly, and that it can kind of creep upon us and gradually deteriorate over a prolonged period of time. And so, for the most part, in my experience of being a musculoskeletal physiotherapist, prevention is better than cure. And if we can intervene early with these, with any problem, but definitely with these pelvic floor problems, then we can prevent a whole world of pain. Unfortunately, I know that you tell me all about the statistics that women can be suffering, or people can be suffering, for something as long as 7 years, I think you said to me, before we actually do anything about it. I mean, that's just bonkers, isn't it, Abby?
It's a minimum of 7 years for most women to come forward and say something about incontinence or pelvic organ prolapse. So that means there are women out there that don't say anything at all, ever.
Yeah, well, that is true. And so, do you know what? I didn't give you a proper introduction because we were having such a technology moment. So, Abby Lord, master trainer with the International Hypopressives Council. Abby is a personal trainer. She's also a Pilates instructor in training, and and I have taken a couple of courses with Abby, and she's an amazing font of knowledge. So thank you so much for giving you time this morning to come along and enlighten us, Abby.
So definitely so from my point of view with the pelvic floor, when it comes to menopause, a lot of women have issues that they don't know about. And then when it comes to the menopause, they have what's called a sudden event. So they're out walking the dog, or they are pushing a wardrobe, or they're lifting shopping bags. And then they suddenly feel something give or go. And for the majority of women that I see at menopause, this has been the issue. And so when they come to me, they're frightened because they don't know what's going on with their body. They've been fine. They had no issues after their pregnancies. No issues at all. They thought everything was going great. So, which is, if they had known that they had issues already, then they could have done something to stop the progress of the issue. It's a standard thing that when you go for your smear, if they see that you have a prolapse, they don't tell you. And I think that this is something that's really lacking in healthcare, because if we had that warning from the person that looks every 3 years, then we'd have much better chance of being able to do something about it before it got so far down the line.
Yeah, and I think this is right. And actually, I was talking to a client of mine last week, a lady who's had a pelvic floor repair,
Right.
and I was asking her because she's had ongoing problems thereafter, and we were talking about this. And I said, what did the consultant say about the rectum? And she said, oh, he said it's a bit floppy, but it's like, this is somehow acceptable, that we should accept that particularly women who have had vaginal deliveries of children, but it's not exclusive to those women, that we accept that muscle tone is not what it used to be. You know, things down there are not what they used to be. But I don't know that this has to be the case. And, you know, and this is where we're kind of on a mission to share information with people to help them to know that there are things you can do, and that actually some of it's quite simple, and that the sooner you start, the better.
Yep. The surgeons tend to say things like, you stretched your ligaments, there's no fixing them. And although this is true that your ligament won't go back to how it was before, like scar tissue, you can remodel the ligament. So you can create, because the ligament's just part of a whole fascial chain, it's like a thicker component or a rope within the fascia in your body. So you can strengthen the fascia round about and the muscles round about to help support that ligament, so that ligament becomes properly functional again. But it's different. It's not the same as it was before. So it'd be more prone to injury later on if you were to injure it again. But if you're doing things like either hyperpressive or Pilates that's designed for your pelvic floor, or personal training for that, there's no reason for you to have any issue later on, you know? So I think telling women that there's all that they look forward to is a downhill fall is not helpful.
No, and I mean, I don't know that we're being told that things are going to go wrong any more than we are told that there are things we could do to help. I think it is, you know, like you were saying around the it's just not talked about, really.
Yes.
And, you know, and it is an absolute and utter fact that we can remodel tissue. It's an absolute and utter fact. And I think what you were talking about then was the suspensory ligament of the uterus. Is that what you're talking specifically about? Yes.
Yes.
Yeah, and you know, these interesting, I mean, we are learning all the time about fascial connections. And so, you know, this ligament has connections to the navel, does it not?
The ligament that has the attachment to the bit that has the attachment to the navel is the bladder, so round from the detrusor muscle.
Okay.
But
Correct me.
everything is part of the same whole. So it's we can't think of things as being separate from each other. So the fact that if you have a bladder prolapse, you go and see a urologist. If you have a uterine prolapse, you go and see somebody else. If you're going to have a rectal prolapse, you go and see somebody else. There's no joined up thinking, you know, to look at how things support each other. So women will go and have the hysterectomy, and they think that that's going to solve the issues. And then they find that the issues are much, much worse, because the uterus that was there, you know, you have your bladder at the front wall, your uterus on top, and then your rectum at the back wall. And if you take this away, then you've got one of your building blocks is missing. And women are they're not really given proper exercises to go away and do to help maintain the anterior pelvic, the anterior wall and the posterior wall. And so they fall in on each other. And then they have breaker problems.
Yes. I mean, yeah, that's fascinating that we're thinking about the lack of joined up thinking being, you know, a big part of, and this is very much the case when it comes to menopause, that it's a whole set of disparate symptoms and yet one common theme, you know, which is the declining in the estrogen levels, etc. But, you know, the most important thing for us to know is that these are our bodies and we're the boss of them. And, and if only we can be in tune with our bodies and to know when things might just be slightly a little awry, and then intervene at that point rather than, you know, not knowing, not exploring what might just be happening, and then not taking action. So we're here today to talk about taking action and doing something to help ourselves. And
so hyperpressives, so the hyperpressives, the way hyperpressives help is the breath work helps to calm your nervous system down. And this, when your nervous system is calmer, you have less anxiety, less heart palpitations, you're able to heal better and to be stronger. We also have the adrenal glands that help to kick in when the estrogen dips. The adrenal glands are supposed to help with the hormone transfer. And if we breathe and open our ribcage the way we do in hyperpressives, we're massaging those adrenal glands and making them work better is the word I'm looking for. Yeah. Because, to be honest, Philippa, when we were 13, we didn't have loads of estrogen. Then we got loads of estrogen that made us a bit drunk. And then we come out the other end and we're angry again, like a 13-year-old. You know, we remember what we were like at 13. So menopause is just our way of adjusting to being angry again, you know, and we've got to find a way to calm that anger and find a homeostasis in our body again. And it's that we're looking for.
Yeah. I think you said something interesting that I never really thought of, but that, you know, the tone in the pelvic floor or the activity in the pelvic floor is influenced by that, by our levels of awareness, arousal, anxiety, whatever you want to call it, that go with that fight or flight, because it was part of the, you know, the primitive programming, so that the pelvic floor is affected directly, not just indirectly. Am I right?
Yes. So the nervous system that directs our pelvic floor only really kicks in properly in rest and relaxation. So if you're anxious, the first thing that happens is that your body, when it's frightened or scared, it looks to protect you by running or hiding. So it's using all of the kind of extremities of your body rather than the base, which is your pelvic floor.
So, okay. So in order for us to get the most out of doing any of those kinds of exercises that people might have heard of, pelvic floor muscle training, Kegels, you know, whatever you want to call it. And of course, we're talking specifically about hypopressives, which is different. We must make that distinction. But, you know, if we are worried or anxious at that time, then we're not going to get the best out of it. And so it is interesting that, you know, hypopressives, let's just go right from the very beginning and tell me kind of like a definition of what it is for people who've never heard of it.
So hypopressives are a global exercise program that treats your pelvic floor as a member of a team. So we're not treating it individually on its own. So we're treating the pelvic floor as if it's a member of your entire body, and your entire team. When your pelvic floor has been damaged, your entire team has to take over in order to help support the pelvic floor while it heals. So you could have had issues with alignment, with breath, with all of these things prior to your pelvic floor trauma. But your pelvic floor was there hanging about going, it's okay, I'm taking one for the team. It's all right, I'll support everybody. And then when you have the pelvic floor trauma, the pelvic floor can no longer take one for the team. So the pelvic floor goes, oh, I can't do it. And unless you start to strengthen your shoulders and your back muscles and your abdominals to help support the pelvic floor from above, and your legs and your feet and everything, then so you're supporting it from below, you can't actually allow the pelvic floor the space to heal. So if you think the pelvic floor is your sexual part of your body, it's where we pee and poo. It's also the bottom of your respiratory system. It's also to do with your alignment, your posture, your ability to run and walk and sit and do all of these things. So it's got a lot of hats that it has to wear. So what we do in hyperpressives is we start with the breath, and we connect the part of the pelvic floor, which is a breath part first. And then we connect the alignment part to the breath part. And then we connect the feet to the breath and the alignment part. And then we connect your jaw. And so we slowly build up connections until your body's working as a team again, because it's forgotten how to do it, which is why you've got so many issues. So if we can just get that team functioning properly again, which is what we aim to do in hyperpressives, then it's not just about the time you spend practicing hyperpressives, but it's the time throughout the day, when you remember, oh, I've got to stand like this, or I've got to relax my jaw, or perhaps I need to work my feet. So it's about a re-education. Yeah, I guess. Does that make sense?
Yeah, no, that's well, it absolutely makes sense to me. You know that taking things in isolation has a purpose, in as much as, you know, it is important that people can appreciate where that part of the body is and what
Yes.
it feels like when it's either relaxing or contracting or, you know, whatever. But to then train in cooperation with the structures that it would normally function alongside. As you say, that team analogy is really powerful.
So when we work with the pelvic floor, when we do the breath work, we connect the pelvic floor so you can feel it opening and closing. And that's important because a lot of women with Kegels, they don't know they're hypertonic. So they go from being tight to tight to tight to tight to tight. And their dysfunction in their pelvic floor is because it's too tight, not because it's weak. So, and quite often they're holding tight because they have a prolapse. So they've been instinctively holding. And these women tend to be glute clenchers. So they actually tighten the bums all the time. So if there's anybody watching this, check your bum and make sure that it's not clenched, you know, because that bum clenching is a sure sign that you're possibly hypertonic in your pelvic floor.
Yeah, well, I mean, there is a whole world of things that can be slightly awry with regards to the pelvic floor, and it is important to, you know, seek professional advice.
Always.
You know, and we definitely both agree on that, I know.
Yes.
But, you know, in actual fact, that for the people who are early in that journey, to get intervention, just general kind of advice can be something that prevents this deterioration in the future. And so, you know, with the proviso, and of course, you know, you talked about the different areas of the pelvic floor, the different functions. So, you know, we can have urinary incontinence, we can have fecal incontinence, we can have prolapse of all of those three different areas, if I'm not wrong.
You can also, the urethra as well is quite a traumatic one for people as well. So you can actually have the urethra at the bottom can actually prolapse as well. So there's more than just the standard ones.
Yeah. So there's a whole world of things that can go wrong, and not just hypotonia is low tone, but the hypertonia that you were talking about, increased tone, and but that's, you know, that's often associated with painful passage through the pelvic floor, and that might be painful intercourse or painful defecation.
Sometimes women don't notice that, though. Sometimes,
So there's always the exception that proves the rule, essentially, isn't there? And, you know, you said an interesting thing the other day to me, which was that there's been no research to tell us what the resting tone of the pelvic floor should be. So, you know,
it's because we're women, I think. I think that research quite often doesn't happen unless it's a male issue. So I'm pretty sure there would be a lot more research if this was something that happened much more often to men.
Yeah, well, it is predominantly in the female population, and having had vaginal delivery of children does increase the risk. But, you know, like we said, cesarean sections, it may be that you had an emergency section at the end of a long protracted labor. Instrument deliveries are particularly traumatic and predispose us to these kinds of problems.
But I have clients too, Philippa, who have had no vaginal delivery and no C-section. You know, they tend to have things like they are sports professionals, or the wind section in orchestras, or somebody who plays a wind instrument. So they're very, very prone to incontinence and prolapse because of the way that they breathe. And a lot of singers who have been taught to breathe into their bellies rather than using their rib cage and the back of their body have also issues, because this constant belly breathing out the front creates loads of pressure down the way, and especially if they're professional singers and they've been doing it for a long time. So I've had some singers that I've worked with, and we've had to retrain the way they think about breathing for singing in order to alleviate the pressure off their pelvic floor.
Yeah, and I mean, it is, although predominantly female, it isn't exclusive to the female population. No. And you know, prostate surgery is something that definitely can predispose to incontinence and actually
erectile dysfunction as well. They don't always tell men that.
Oh yes, yes.
So the men I've worked with have come to me because they've been in their early 50s and they have erectile dysfunction because of elective prostate surgery. And it's been pretty, they didn't realize that's what's going to happen to them.
Huh? That's quite an oversight, isn't it, in the pre-op conversation?
Yeah. So they also get a rough ride as well.
Yeah, and actually my husband was a fast jet navigator and spent his career pulling G, shall we say.
Yes.
And you know, that's kind of sending everything downwards, isn't it?
It does.
He definitely suffers with piles. Now, correct me if I'm wrong, but I think hyperpressives can help piles as well. Am I right?
Yeah, so it alleviates all the tension and the pressure off the pelvic floor. So for both men and women. So I've had men who've come to me with rectal prolapse, and it's really helped them because men can still have rectal prolapse. It's anything, and I've had a gentleman who came to me who was in late stage prostate cancer, and he used to use the breath work to alleviate the pain. So when he was doing the breathing, it lifted all the tension off his prostate, which was enlarging all the time, and he used to use it for pain relief.
Oh wow! I mean, that's so awesome to be able to help people, isn't it? And so, you know, we keep talking about the breath, and people really, you know, what's inside of us, we're not necessarily thinking about it every day as we go about our business, are we? But the connection between the diaphragm, the thoracic diaphragm, and the pelvic diaphragm is a very real connection in terms of the dynamics, the pressure dynamic. Am I saying that right?
Yes, it's right. So as we inhale and stretch our ribcage out to the side, that allows our pelvic floor to stretch out. And as we exhale and draw our ribcage back together again, our diaphragm underneath here lifts up and our pelvic floor lifts with it. This is because we've got some really cool muscle and fascial connections. We have the psoas muscle that comes right down your back, from where your bra strap is, down your back, into your pelvis, into your femur at the front. So every time you inhale and use your back muscles to inhale and exhale with, you allow that to relax down, and then you draw it back up again. And so you've got this beautiful synergistic movement happening. Now, especially for bladder prolapse with breath, if you think about your detrusor muscle, so your detrusor muscle is a muscle that goes around your bladder, and you have a beautiful connection that goes from that to the medium ligament that goes to your belly button. And then from there, it's a beautiful fascia connection through your diaphragm to your liver. So every time you inhale, stretch out, you allow the detrusor muscle to relax and then draw back up again. So you have just this beautiful synergistic movement.
Yeah, and I mean, I know that I know that there's a place for pelvic floor muscle training, and I know that people are getting taught these exercises, but they're so much more powerful if we combine them with, you know, appropriate breath synergy because of that relationship with the diaphragm, and of course. You know, these are things that are skills that we learn, that we're not born knowing these things, although, you know, it is an automatic thing that happens. Well, you're shaking your head there. Is that because children, you know...
Well, children, my children at 8 and 10 still breathe properly with their rib cage.
Okay.
But when I was a teacher at high school, you used to watch them come in first year. So that's about 12.
12.
And they'd start off, you could see them like this. Oh yeah, they're proud of themselves still, they're confident. And then as they went through the years, they started to do this. And you could see them folding in on themselves. And then they got their mobile phones. And if you try and breathe like this, it's really difficult, you know? So I believe it's something that we learn as we go through school. And I think that if breath education was taught in school, we'd have fewer problems with pelvic floor, with posture, with alignment, with gait pattern, with all of these things later on.
Yeah, I mean, I don't disagree, and breathing dysfunction is a whole area unto itself, and of course that contribution to mood and anxiety and emotion as well, that is so very real with the breath, and that we're often thrown a bit of a spanner in the works when people start to talk about, as you say, belly breathing, diaphragmatic breathing being something that starts in the belly. And there's a lot of confusion, really, isn't there?
There is, but there's a place for it. So there's some, so for example, the fire breath in Kundalini Yoga uses the abdominal breath. And it's got a purpose there. It's so that you feel that kind of fire being stoked. But it's just for that exercise. It's not for life. Yeah. Wim Hof has a same kind of fire breath, you know, but it's not for his whole program. It's just for one part of it. You know, he encourages the lateral breath for the rest of it. You know, so there's the nidra in yoga as well, where there's a bit of an encouragement to feel the softness in your belly as well. So there are places for it, but it's not a day-to-day breath. It's something that's designed to help you understand something else about a movement pattern.
Yeah.
But yes, no, you're right. It's people come to me and say, "Oh, but I diaphragmatically breathe," and I'm like, "Well, if you didn't diaphragmatically breathe, you'd be dead." So we all diaphragmatically breathe. It's just about optimal breath.
Yes, yeah, and what you're talking about, our default strategy, the strategy that we use unconsciously as we go about our lives. And so for the most part, most of us are unconsciously incompetent when it comes to lots of things. You know, movement and breath are our sort of passions and our things that we're particularly interested in. But, you know, language is another thing, communication skills. You know, we can be unconsciously incompetent in a lot of different things, and maybe that's a blessing that we don't really know what's going awry. But for us, what we really want to do is to take people to a place where we explore lots of strategies, put an optimal strategies, so that the body can practice doing things the right way, doing them well. And first of all, we do that in a conscious mindset, so that we're practicing it with instruction in a class situation, perhaps, or even as an individual. And we start to be able to understand this for ourselves. And maybe we start to understand that we've been doing it wrong. And that's the first step, you know, to learn that there's room for improvement. And then over time with practice, that the hope is that these strategies become embedded in our everyday normal. And so we're then unconsciously competent as we go about our lives.
Yeah. That's exactly what I'm looking for in my clients.
Yeah.
And sometimes, you know, Philippa, I use bits from Feldenkrais and bits from Pilates and bits from personal training. Not one size fits all.
No. Yeah, and that's a really important thing, that an experienced teacher, a seasoned teacher, and you're not quite as seasoned as I am, Abby, but you know, Well, you've been very passionate because you had a terrible experience, didn't you? And that's driven you to this level of of learning, self learning, and education. So,
So yeah, I had 3 prolapses. So I had bladder, uterus, and rectal prolapse. And my birth was very traumatic. His birth was very traumatic. And I always encourage people who've had a traumatic birth to get some counselling before they start working with their body. I encourage them to work with their mind. So I encourage them to get some sort of talking therapy, because the trauma that you experience during a traumatic incident is in your tissues. And you have to release the emotion first before you can start to heal the tissues. And quite often I don't always know when a client comes to me that's what's happened. I don't always know. They don't always tell me. But we'll start to do the breath work, and they'll suddenly have this release where they burst into tears. And at that point, I say, let's stop. And I'd like you to go and see someone first. And I suggest types of therapies for them.
Yeah. Yeah, that is fascinating, and it's increasingly being talked about, the link between trauma and tissues, and that the first piece of work sometimes is to deal with the mental, emotional sort of trauma that you might have experienced.
So my healing actually accelerated once I could talk about the birth without bursting into tears. So it was very much a journey of self-discovery with that.
Yeah, and I do think having had the experience for yourself, it does generate empathy for your client's journey that they're on. But equally, we both acknowledge that everybody's journey is individual to them.
Yes.
You can have a tiny
You can have a tiny prolapse. You can have your surgeon say, it's tiny, we're not going to do anything about it. You're making it up, it's in your head. And you can have more symptoms than somebody that has a stage 3 prolapse. So we have to treat everybody as an individual and acknowledge what they're going through. And that acknowledgement also helps them to heal. Telling them that it's in their head is like the worst thing you can do,
Yeah, absolutely. To endorse people, that's the wrong word. What's the right word, Abby?
To don't do this to me.
This is the menopause.
Validate.
There you go. Yeah, absolutely. We should all be validated. Our experiences are our own, and in research, it's an N of 1, isn't it?
Yes.
But this is really just for us to be able to share some of the things that we're interested in doing, helping people to deal with, and so thank you so much for giving me time today. I really appreciate it. I will share with people where they can find you if there's any assistance required. And the thing that we really want to do above all else is to start to dispel the myths, to spread the word that everybody's got a pelvic floor. Actually, before I say goodbye, I had a lady client of mine, and she really thought that only women had pelvic floors.
People do?
Yeah, I mean, we've all got one, and along with all the other things that we're trying to fit into our busy lives, it's important that we take care of our pelvic floor as well. So thank you again for coming along. It's lovely to see you. Take care and have a lovely day.